Hello everyone and welcome to today's webinar broadcast, Hepatitis C Elimination Starts with Diagnosis. This webinar is part of the Abbott Diagnostics webinar series, Innovations in Science to Transform Healthier Futures. I'm Susie Valdez and I am pleased to be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by Abbott. Abbott is committed to helping you live your best possible life through the power of health. For more than 125 years, they have brought new products and technologies in the world in nutrition, diagnostics, medical devices, and branded generic pharmaceuticals that create more possibilities for people of all stages of life. Today, 94,000 members of the Abbott team are working to help people live not just longer, but better in the more of 150 countries they serve. For over 40 years, Abbott has been committed to delivering the highest quality products to serve our hepatitis in vitro diagnostics community. For more information, please visit them at www.abbott.com. Before we begin, I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located at the lower left of your presentation window. Type that question into the box that appears on the screen, and we'll answer as many questions as we have time for at the end of the presentation. Also, notice that you're going to be viewing the presentation in a slide window. To enlarge that window, just click on the screen icon located on the lower right. If you have any trouble seeing or hearing this presentation, click on the support button at the top right of your presentation window, or use that Q&A button and let us know you're having a problem. Good news, this presentation is educational and thus offers continuing educational credits. Click on the button at the bottom left-hand corner and follow the process for obtaining your credits. Without further ado, I'd like to now introduce today's speaker, Dr. Jean-Michel PAWLOTSKY. Dr. Jean-Michel PAWLOTSKY is a professor of medicine at the University of Paris. He earned his medical degree in hepatology and gastroenterology in 1992, as well as his PhD in molecular virology from the University of Paris, France. He is the director of the National Reference Center for Viral Hepatitis B, C, and D, and the Department of Virology, and the director of Academic Department, Viruses, Immunity, and Cancers at the Henri Mondor University Hospital in Paris, France. He focuses on teaching and research in virology, primarily hepatitis viruses and liver oncology. Dr. PAWLOTSKY is active in numerous professional societies and has been acting as the Secretary General of the European Association for the Study of Liver between 2005 and 2009. Dr. PAWLOTSKY has been an Associate Editor of Hepatology, an Associate Editor of Gastroenterology, and is a member of the editorial board of the Journal of Hepatology. He has a noted career contributions, including the publications of over 500 articles and book chapters in his area of expertise and over 500 invited lectures at international meetings. I'd like to now turn the presentation over to our speaker. Welcome, Dr. PAWLOTSKY.
Today we will discuss the role of the core laboratory in reaching the World Health Organization HCV elimination goals, and we will discuss how we can improve access to care through diagnostics. This slide shows my conflict of interest disclosure, and in the first part of this presentation I would like to discuss the WHO policy to eliminate hepatitis C virus by 2030. Hepatitis C virus infection belongs to the top 10 leading causes of mortality, and it has been ranked 10th most important cause of mortality in 1990 and went up to the 7th cause of mortality in 2013, explaining that without active intervention, viral hepatitis may continue to move up as one of the leading causes of death globally. Currently, the prevalence of HCV infection has been estimated to approximately 71 million people worldwide, and HCV-related death occurs in approximately 700,000 to 1 million people every year, making HCV a very important public health issue. This slide shows the worldwide prevalence of HCV infection, and as you can see here, the prevalence widely varies from one country to another. The prevalence is relatively low in Western Europe and a little bit higher in North America, between 0 and 0.8%. And there are countries of very high endemicity, such as the Russian Federation, Eastern Europe, Egypt, and some countries in Asia. The size of the circles indicates the total number of infected patients in every area and every country. And importantly, you can see that the vast majority of patients with HIV infection live in lower to middle income countries and upper middle income countries, 47 and 26% respectively, 19% in low-income countries, and a very small minority, only 8% in high-income countries where most diagnostic and treatment tools are available. This slide now shows the heterogeneous distribution of HCV genotypes worldwide, and as you can see here, genotype 1 is by far the most frequent genotype in every region. It represents, in red, more than 3/4 of patients in North America, essentially subtype 1A. Genotype 1 is also very frequent in Europe, where it represents a little bit more than 50–60% of patients. It is also highly prevalent in Asia, but other genotypes are increasing. Genotype 3 is highly prevalent here in green in Western Europe, representing approximately 1/4 of patients, and very highly prevalent and dominant in the Indian subcontinent, whereas other genotypes, such as genotype 4, are frequent in Africa. Genotype 4 is also increasing, especially in the population of intravenous drug users in Western Europe, and genotype 5 is seen in South Africa, whereas genotype 6 is frequently found in Southeast Asia. So a very heterogeneous distribution of the different HCV genotypes, but overall HCV is present in every continent and in every country. For these reasons, and because of the very high mortality rate associated with HCV infection and the important morbidity related to the infection, the World Health Organization has launched a strategy to eliminate HCV by 2030. The term elimination could be debated, and we should maybe rather speak about control, making a frequent disease a rare disease. But the goal has different targets, and these targets split into prevention targets, testing targets, and treatment targets. The prevention targets are the following. The goal is that all blood donations be screened by 2030 everywhere in the world. This is far from being the case right now. And that 90% of people have access to safe injections. The testing targets include 90% of people who are aware of their infection. Currently, the vast majority of patients are unaware of their infection in most countries in the world. And the treatment targets include that 80% of HCV patients be treated and 90% reduction in new HCV cases is achieved. If all of these targets can be reached in the next 15 years, then we will have eliminated, or more precisely controlled, viral hepatitis as a public health issue by 2030. Obviously, this may look like a fantasy. It's very difficult to achieve, but we will see in a moment that there are tools that may help us to achieve this very ambitious goal. Currently, the HCV diagnosis and treatment rates are extremely heterogeneous throughout the world, and especially throughout Europe. This has been well studied in Europe, and you can see here the heterogeneity of the treatment rates shown in the x-axis and the diagnosis rates shown in the y-axis. Some countries have done pretty well. As you can see, France is leading in terms of treatment rate, very close to Germany. Other countries have diagnosed very well, such as Malta, Finland, Luxembourg, but are a bit late in terms of treatment. And some countries in Europe, especially in Southern and Eastern Europe, are extremely late in their treatment and diagnosis strategies. And this includes countries with very high rates of infection and very large number of patients who are still unaware of their infection and do not have any access to therapy. So much progress remains to be made, and there are several challenges and barriers to HCV management that have been identified so far. Some of these barriers are related to the perception of the disease, with the low patient awareness I mentioned before, and the issue of stigmatization of infection that may prevent patients from being screened and diagnosed. There are barriers related to diagnosis when testing is not freely available, when access to testing is limited, or when testing is available but linkage to care fails to bring these patients to efficient care and to be treated. There are challenges related to treatment itself, with restricted access to effective treatment in some areas, and a lack of infrastructures and human resources in many low to middle income countries that make that even if the infection is diagnosed, the patient will not have access to a good therapy in their country. Finally, there are issues related to surveillance, and systematic monitoring of the disease has not been established everywhere. And altogether, this makes that treatment and HCV management is remaining difficult, complicated in many countries. How could we improve these? And the focus of the second part of my presentation will be on the role of biological tools in HCV elimination and in trying to fight against these different barriers and challenges. The first point, and this is probably the most important one, is screening of HCV infection. I said before that the vast majority of patients are unaware of their infection, which is very often a silent infection. It is important that these people be screened for their infection and that patients who carry the virus be identified and then engaged into care and treatment. The World Health Organization, WHO, has recently issued guidelines, and these guidelines are very precise in what should be done. In all settings, the guidelines say, it is recommended that serological testing for HCV antibody be offered with linkage to prevention, care, and treatment services to adults and adolescents from populations most affected by HCV infection. This includes patients who are part of a population with high HCV seroprevalence and patients with a history of exposure and or high-risk behaviors for HCV infection, and also in adults and children with a clinical suspicion of chronic viral hepatitis. Second point is that in settings where there is a more than 2% or a more than 5% HCV antibody seroprevalence in the general population, it is recommended that all adults have access to and be offered HCV serological testing with linkage to prevention, care, and treatment services. And finally, birth cohort testing may be applied to specific identified cohorts of older persons at higher risk of infection and morbidity within populations that have an overall lower general prevalence. This is a very detailed and precise guidance for HCV testing. The WHO adds that to test for serological evidence of past or present infection in adults and children above 18 months of age, an HCV serological assay, antibody or antibody combined with antigen, using either rapid diagnostic RDT or laboratory-based immunoassay formats that meets minimum safety, quality, and performance standards with regard to both analytical and clinical sensitivity and specificity is recommended. So two different assays can be used, an ELISA assay, centralized, or locally a rapid diagnostic test, RDT. Finally, RDTs are recommended in specific settings where there is limited access to laboratory infrastructure and testing, and or in populations where access to rapid testing would facilitate linkage to care and treatment. We have the use of dried blood spots, another type of assay, which I will show you in a minute. The use of dried blood spot specimens for HCV antibody serology testing may be considered in settings where there are no facilities or expertise to take venous whole blood specimens. RDTs are not available or their use is not feasible, and there are persons with poor venous access, such as patients who are in drug treatment programs, prisoners, etc. This is what WHO says, and there have been other guidelines published recently, including the guidelines from the Infectious Disease Society of America and the American Association for the Study of Liver Diseases, which say that all persons recommended for HCV testing should first be tested for HCV antibody, anti-HCV, using an FDA-approved test. This is for the United States, and FDA-approved tests include laboratory-based assays, enzyme immunoassays, and one point-of-care assay, the Oraquick HCV Rapid Antibody Test, which is currently FDA approved in the United States. Finally, the European Association for the Study of the Liver, EASL, recommended the following, and this is very much in line with the WHO guidelines. Screening for HCV infection is presently based on the detection of anti-HCV antibodies. Rapid diagnostic tests, RDTs using serum, plasma, fingerstick, whole blood, or crevicular fluid, saliva as matrices can be used instead of classical enzyme immunoassays to facilitate anti-HCV antibody screening and improve access to care. And all blood sampled on dried blood spots can be used as an alternative to serum or plasma obtained by venipuncture. And you can see here 3 different kinds of tests, which I would like to discuss now more into detail: enzyme immunoassays, rapid diagnostic tests, and dried blood spots, which all are extremely helpful in the different populations indicated by the WHO guidelines for screening of HCV infection. First, the ELISA tests. The ELISA tests have many advantages. They are simple, they are standardized, they are generally fully automated, and it's possible to have random access for urgent diagnosis, meaning that you can stop the series you're performing to include one sample that must be urgently tested, and they remain relatively cheap, not very cheap, but relatively cheap. These ELISA tests, however, have disadvantages. They require a central lab, they require equipment, which is generally extremely expensive and big, takes a lot of space, and they require trained personnel, and this is not always possible everywhere in the world. So the rapid diagnostic tests are different, and I'm showing you here the example of one of these tests, and you can see here that it is possible to load the blood sample or saliva sample here on the test, and then there will be a migration of this blood upstream through the nitrocellulose strip until the blood sample or saliva sample meets with antibodies or antigens. In that case, it would be antigens. There will be an antibody-antigen reaction, and this will be witnessed by the appearance of a band, and the appearance of these bands indicate that the anti-HCV antibody is present in the sample, which again can be blood or saliva. It's a very simple principle, very easy to do, and these rapid diagnostics, which include the physician's office, eventually general practitioners, the emergency room, the intensive care unit, outpatient clinics, rural areas, and even patients' homes if necessary. And they can use original specimen matrices as alternative to whole blood, serum, or plasma for venipuncture, and this includes fingerstick whole blood, as shown here in this slide, and also oral fluids, as shown above. And it's possible to take saliva and detect anti-HCV antibodies with the RDTs. What is the performance of HCV antibody RDTs? You may think that RDTs are all equally good. This is not the case, and I chose to show you the results of this study that we performed in my lab in 318 HCV positive patients and 171 HCV negative patients. And you can see here that if the performance of the first 2 assays was excellent, with a very good specificity, sensitivity, positive and negative predictive value, the performance of the last one was really, really poor, with a sensitivity of only 62.7% and a negative predictive value of 49.6%. And this is just to emphasize the fact that all RDTs are not equal. They are not all performing very well, and it is very important when you use an RDT that this RDT has been tested before and that its specificity, sensitivity, positive and negative predictive values have been correctly evaluated and confirmed to be good. So recently there was a publication of a meta-analysis of more than 13,000 individuals included in 18 studies between 1994 and 2001. 4,259 specimens were tested in whole blood from venous and capillary sampling, and 3,994 specimens from saliva. And as you can see in this meta-analysis of appropriate RDT, the overall performance was very good, with a specificity of 99.5 for all blood, 98.2 for saliva, and a sensitivity of 98.9 for all blood, and 97.1 for saliva. So excellent performance. And interestingly, there were, in another meta-analysis published more recently, 30 studies, more than 17,000 specimens, there was a comparison of the parameters that could influence the performance of the HCV RDTs. And importantly, the year of testing did not have any influence on specificity or sensitivity. The fluid from which this was done did not influence either the performance in terms of sensitivity and specificity. The only parameter that had an influence was the location, and these assays performed better in industrialized countries than in developing countries, which could be problematic because it is in developing countries that these tests may be the most useful. Therefore, it is very important that the performance of these RDTs be validated not only in high-income countries, but also in low-income countries, middle-income countries, where these assays will have all their value. The other possible way by which you can screen for anti-HCV antibodies is the use of dried blood spots. The principle of the dried blood spot is very simple. The first step is fingerstick collection, where you take the patient's blood and load it onto the paper. Then there is a barcode which allows you to identify the patient and to collect the blood sampled and dried on the paper directly, the filter paper. And this blood sampled on the filter paper will be used in an automated sample processing, which is very similar to what we do with plasma, in a central lab. So this allows you to send the dried blood spot to a central lab where an ELISA test, a very classical ELISA test, will be performed. DBS are currently endorsed by the World Health Organization and form the backbone of HIV viral load and resistant testing scale-up efforts globally, so there is a lot of experience on dried blood spots in the HIV field. And DBS are minimally invasive and are very useful in some low-income, middle-income countries, but also in marginalized populations of industrialized countries, such as injecting drug users, men who have sex with men, sex workers, etc., etc. And they are currently being implemented in many settings to help screen and diagnose HCV infection. So what are the advantages and disadvantages of DBS? Their advantages are the low volume required, which is in the order of 50 to 70 macroliters, a good stability of the biological matrix. They are easy to collect and to mail at room temperature, and different types of analysis can be done, including serological, but also molecular, pharmacological analysis. All of this can be done on DBS. The disadvantages, however, are their lower analytical sensitivity than the classical biological matrices, such as serum and plasma, the fact that there are no standardized procedures, and the fact that storage at -20 degrees Celsius may be required if the DBS are not immediately analyzed, and this may impair the quality of the analysis if the DBS are not sent quickly and frozen within a few days after being shipped to the central lab. This slide shows you the performance of HCV antibody detection by third-generation ELISAs in samples taken from dry blood spots. Here it's fingerstick blood sampling. And as you can see here, population of HCV seronegative patients, a population of HCV seropositive patients with resolved infection, and a population of HCV seropositive patients with chronic infection, meaning that they have detectable HCV RNA. We had to re-establish the detection cutoff for the anti-HCV antibodies, but with the new cutoff established, the discrimination was excellent, and it was very easy, as you can see here, with a high sensitivity of 99.1% and a high specificity of 98.2% to discriminate among people who were HCV seronegative and people who were HCV seropositive. Therefore, it is very easy and reliable to test for anti-HCV antibodies with blood or with blood taken from dry blood spots. The second point when anti-HCV antibodies have been detected is to confirm the diagnosis of infection and decide to treat or not to treat, and the decision to treat is made based on the presence of HCV RNA. Therefore, HCV RNA testing is a standard of care to confirm HCV diagnosis so far. And this is what is indicated in the WHO guidelines, which say that directly following a reactive HCV antibody serological test result, the use of quantitative or qualitative nucleic acid testing for detection of HCV RNA is recommended as the preferred strategy to diagnose viremic infection. However, the WHO adds that an assay to detect HCV Core P22 antigen, which has comparable clinical sensitivity to nucleic acid testing, is an alternative to NAT to diagnose viremic infection. Therefore, the WHO acknowledges that either HCV RNA testing or core antigen testing can be used to confirm diagnosis and bring patients to care and therapy. EASL is on the very same line, and in its most recent recommendations, EASL indicates that if anti-HCV antibodies are detected, HCV RNA should be determined by a sensitive molecular method. HCV RNA detection and quantification should be made by a sensitive assay with a lower limit of detection of less than 15 international units per ml. And if HCV RNA testing is not available or not affordable, HCV core antigen detection and quantification by enzyme immunoassay can be used as a surrogate marker of HCV replication. Finally, EASL adds that the HCV genotype and genotype 1 subtype, 1A or 1B, must be assessed prior to treatment initiation and will determine the choice of therapy among other parameters. Finally, IDSA and IASLD are on the same line. If the result of the anti-HCV test is positive, current infection should be confirmed by a sensitive HCV RNA test. Qualitative HCV RNA testing is recommended prior to the initiation of antiviral therapy to document the baseline level of viremia, which is a baseline viral load. The core antigen is not recommended by the IDSA and IASLD guidelines because these assays have not received FDA approval yet. And testing for HCV genotype is recommended to guide selection of the most appropriate antiviral regimen. So let's now discuss the different assays that are available and how they can be used. This slide summarizes the dynamic ranges of quantification of various assays that are available in different countries. And as you can see, these assays cover very well the low viral loads on the left, which are seen on treatment in patients who respond to therapy, up to the very high viral load that are seen before therapy or in various morbidity conditions. The gray area indicates where 95% of patients stand, that is 95% of patients have their viral load here, which is comprised between 510 to the 4 and 510 to the 6 international units per ml at the start of therapy. And you can see that the assays cover very well the pre-treatment baseline viral loads, as well as the on-treatment viral loads and the goal of therapy, which is a sustained biological response that corresponds to an undetectable HCV RNA at 12 weeks after the end of treatment. Different assays have been developed. As I said, most of them are centralized on big machines, automated machines in the central lab. They are not yet real point-of-care tests. We should probably speak more about near-care HCV RNA tests, and there is one such near-care test which has been recently developed, and I'm showing it here. This is a very simple system with a cassette which is filled in by the blood sample. The cassette is put in the machine, and the machine after a few minutes will give you the HCV RNA level with an excellent correlation, which you can see here on the right, between the HCV RNA level measured in this assay and the HCV RNA level measured in another reference assay. What about testing for HCV RNA from DBS? I said before that DBS can be used for molecular testing, and we assess the ability of samples taken on DBS to be used for HCV RNA testing by comparing the HCV RNA level in serum specimens on the x-axis with two different assays, with the HCV RNA level in all blood specimens taken from DBS on the y-axis. And as you can see in both instances, there was an excellent correlation between the two HCV RNA levels from the same patient, meaning that DBS quantification of HCV RNA is reliable. However, the absolute number should not be taken into consideration, as the absolute number in international units per ml here in the DBS was shown to be 1.5 to 1.7 log lower than the absolute number for the same sample if the sample was tested directly from serum or plasma. So good to detect HCV RNA, to say HCV RNA is present, but the viral load, the number which is given with the DBS, is not as reliable as the number that is given by directly the HCV RNA assay when taken from serum or plasma. So what about the HCV Core Antigen test? I said that this test is a surrogate marker of HCV replication, and it has some advantages over NAT testing: reduced operational expenses, stability at room temperature for 96 hours, short time to result, approximately 60 minutes, which is shorter than NAT testing, and no need for NAT skills. However, this test must be performed in a central laboratory on an automated device, and this may limit the use of this assay to places that have access to such a central lab. This slide illustrates the fact that the core antigen test is a surrogate marker of HCV RNA levels, and you can see here in a study we recently published a very good correlation between the HCV RNA level on the x-axis and the HCV core antigen level on the y-axis. The analytical sensitivity of the core antigen test is slightly lower than the analytical sensitivity of the HCV RNA assay, with a lower detection of the core antigen assay, which is equivalent to approximately 500 to 3,000 HCV RNA international units per ml, and this varies according to the HCV genotype. And there have been rare false negative results reported, meaning a core antigen negative HCV RNA positive result. So sometimes the core antigen may miss HCV, the presence of HCV replication, but this is extremely rare. And this has been assessed in a recent systematic review of HCV core antigen versus HCV RNA. And you can see here the Oraquick curve that shows a good sensitivity and a good specificity, and overall a very good predictive value of core antigen on the presence of HCV RNA, meaning that the test can be used confidently to test for HCV replication. And this slide shows you the correspondence between the presence of HCV RNA and core antigen. And you can see here that the two assays were concordant in the vast majority of cases. 41% were positive in both assays, and 54% were negative in both assays. There were very few discrepancies. 46 patients had a false positive of the core antigen assay, meaning approximately 0.57%, and there were also rare false negative results, 3.5%, but you have to consider that in this series there were patients who were on treatment, and therefore this may reflect the lower analytical sensitivity of the core antigen assay as compared to the nucleic acid testing assay. So overall, the conclusions of this systematic review are that there is currently evidence that suggests that the HCV core antigen detection performs as well as RNA-based assays for HCV management, and that the use of antigen tests could improve access to HCV care in under-resourced healthcare settings, which now remains to be validated. We also tested the ability of testing for HCV core antigen from dry blood spots, and here we were disappointed that this did not perform well, and this is due to the lower analytical sensitivity of the core antigen assay. There was, as you can see here on the left, a good relationship between core antigen assay and the HCV RNA level, but a large number of patients were undetectable with the core antigen, with a very big difference in the absolute value of 2.46 logs between core antigen in blood taken from seroplasma and in blood taken from DBS, and this indicates that the core antigen test is not sensitive enough to be used from dry blood spots and therefore should be limited to use on serum and plasma. The last point in the recommendations from WHO, AASLD, IDSA, and EASL is the genotype, and this slide summarizes the different treatment options as recommended by the recent EASL guidelines. And this indicates that even if we have many different treatment regimens, these treatment regimens indicated here should be tailored to the genotype, and not all genotype have the same treatment. Genotype 1 here has several options: Idipasvir, Sofosbuvir, Sofosbuvir, Verpatasvir, Abitavir, Paclitaprevir, Ritonavir, etc., whereas it's much more limited for genotype 2 or 3, which can be treated only with Sofosbuvir, Verpatasvir, or Sofosbuvir, Declatasvir. A little bit more options for genotype 4, and slightly less options for genotype 5-6. All this to say that as soon as diagnosis is confirmed and you decide to treat the patient, it is extremely important that you identify the HCV genotype and also the subtype, because treatment will be tailored to this information. There are different assays available for HCV genotyping, but the most widely used assay, and probably the most accurate one, is the line probe assay, INNO-LIPA. And this assay is a reverse hybridization-based assay which uses nitrocellulose strip onto which different probes have been loaded. And these probes are used in the 5' untranslated region, but also in the core region, in order to discriminate well among genotype 1 subtypes 1A and 1B, and also to discriminate genotype 6 from genotype 1. This assay has been shown to be very accurate and is widely used to identify the HCV genotype. It's also possible to identify the genotype in blood sampled on dry blood spots. We validated this, and in a series of 263 patients, we found that there was a 100% concordance at the genotype level. Subtyping was not as easy as genotyping. Subtyping failed in 16 cases and was erroneous in 1 case, but overall, with the genotype 1 to 6, DBS can be confidently used. The third potential step is HCV-resistant testing. Is it necessary to test for HCV resistance prior to therapy? The answer is no. This is what EASL recommends. EASL says that systematic testing for HCV resistance prior to treatment is not recommended. Indeed, this obligation would seriously limit access to care and treatment regimens to be optimized without this information. It is very important, and when we discussed the EASL guidelines, we estimated that making an obligation of resistant testing would make that the vast majority of physicians worldwide would not have access and would not treat patients. Knowing that it's possible to optimize therapy, as I will show in a second, it is not necessary to do it. However, what is not recommended is not forbidden, and if some physicians have easy access to a reliable test assessing HCV resistance to the NS5A inhibitors, then they can use these results to guide their decisions, and the EASL guidelines provide guidance for people who do not have access to resistant tests and guidance for people who have access to the resistant test. What are the reasons for not recommending HCV resistant testing? They are listed on this slide. Number one, there is no standardized assay that has been externally validated for its performance and is easy to routinely use, available as a purchasable kit. No assays. No standardized interpretation or reporting of HCV resistance data. No precise definition of clinically relevant resistance-associated substitutions, or RASes, and no clear-cut guidelines from international societies to guide treatment decisions. Altogether, this makes that we could not recommend the use of resistant testing in patients prior to therapy. And the guidance is the following. The guidance shows you that if the resistant test is not available, you should optimize therapy to avoid treatment failure, and guidance is shown. The tricks are very simple. If you think the patient could have an influence of the presence of resistance-associated substitutions, you should add ribavirin and prolong the duration of treatment, or prolong the duration of treatment, and there are different recipes to do that with the different treatment regimens, and I will not go into detail in this. On the other hand, if you have access to a test which is available, which is reliable, has been validated, is easily interpretable, and is understandable by the clinician, then the presence of NS5A assays conferring high-level resistance will indicate that only these patients who have detectable NS5A assays should add ribavirin and or increase treatment duration in those patients. The point is that this applies to current treatment regimens, but the next generation of treatment regimens will not need any adaptation based on the presence of NS5A assays, and therefore this will very soon become irrelevant. The fourth and final point is monitoring of treatment efficacy. When you have studied treatment, it is important to monitor treatment efficacy. And here, EASL recommends the use of a real-time PCR assay with a lower limit of detection of less than 15 international units per ml to monitor HCV RNA levels during and after therapy. And EASL also indicates that, like for the confirmation of diagnosis, measurement of HCV Core Antigen levels by EIA could be used as an alternative to HCV RNA level measurement to monitor treatment efficacy during and after therapy when HCV RNA assays are not available or not affordable. But this slide shows you the monitoring of several patients in a study we recently published with two different assays. And you can see that if you use two different assays, the HCV RNA levels are extremely close to each other. And this confirmed that the HCV RNA tests currently are very well standardized and will allow you to monitor the response to therapy extremely accurately. And this other slide from another study we performed now shows the relationship between HCV RNA levels and in the x-axis and HCV core antigen levels in the y-axis in a large number of patients included in a clinical trial of new HCV drugs. And these patients including both baseline viral load, high viral loads, and low viral loads on treatment. And as you can see, there was an excellent correlation between the HCV RNA level and the core antigen level, both at baseline and on treatment. And this clearly validates the use of core antigen testing to monitor the response to therapy. The response is essentially monitored at 12 weeks post-treatment, the sustained virological response. And this is something that can now be done with the core antigen test. So this brings me to my conclusion, and the conclusion is the following. A number of assays and tests now exist to diagnose HCV infection and help clinicians to make appropriate therapeutic decisions. Novel assays are or will soon be available, and they will allow HCV treaters to simplify diagnosis, assessment of severity, treatment decision, and monitoring in order to optimize access and linkage to care. And if we go back to these initial strategies to eliminate HCV by 2030, you understand well that biological tools cannot do much on the prevention targets, but they can definitely improve the testing targets. The goal to have 90% of people who are infected aware of their infection by 2030, and also improve the treatment targets, make sure that 80% of HCV patients will be treated, and that there will be a 90% reduction in new HCV cases by targeting specifically high-risk populations and removing HCV from these important reservoirs. And this makes us confident that within the next 10, 15, maybe 20 or 25 years, we'll be able to control HCV infection as a public health issue. It may not be exactly 2030 in all countries, but with the drugs we have and with the tools we have, this has become an achievable goal. So on this, I would like to thank you very much for your attention, and I will be pleased to take any question you may have. Thank you very much.
Thank you, Dr. Pawlowtsky, for that informative presentation. Before we get started on the question and answer session, I'd like to remind the audience how to submit questions. You can submit questions by typing into the Q&A box, which can be found by clicking on the green Q&A on the lower left of the presentation window. We'll try to answer as many questions as we can. So let's get started. We have a wonderful audience today. Our first question is, given the two-step process for diagnosis, what can I do to streamline current testing practices?
Identify your target well. I hope you can hear me. So I think it's very important that you identify your target well and identify the best people to screen the population. I think in many countries, general practitioners are a very good target for screening. They can be informed, they can be made aware, they can look for risk factors, identify which patient should be tested. And generally, the patients are faithful to their general practitioner and therefore will come back to get the result of the anti-HCV test and get confirmation. If the patient is anti-HCV antibody positive, indeed, this patient can be infected with HCV RNA, and this is why we need confirmation. Or this patient may not be infected, may be HCV RNA negative, and in that case, the general practitioner will be very helpful also to explain that there is a marker in blood that the patient probably met the virus at some point, but this patient is not infected, is absolutely safe, does not need to be followed, and can be reassured. So I think really the general practitioner is key, as well as some practitioners who are working in specific areas where there are many people, such as people who inject drugs, prisoners, with a high prevalence of HCV infection and a high risk of transmission. So I really believe identifying which people will be running the screening is extremely important. These people should not be trained to treat patients. They should really be trained to be informed about hepatitis C and be able to identify which patients, make them aware, provide the right information, and then send to a specialist who will start treatment after evaluation.
Thank you so much, Dr. Pawlowtsky. Our next question from our audience is, why is confirmation testing needed?
Well, so far, confirmation is needed because the screening test is an anti-HCV antibody test, which detects the presence of antibodies, but is not able to confirm the presence of active replication. So people who do not have antibodies are not infected, but not all people who have antibodies are infected. And for that reason, it's necessary when somebody has anti-HCV antibodies to identify which patients are HCV RNA positive, infected, and should be followed and sent to a specialist for potential treatment. This is the reason why we still have to do it in a detection and confirmation procedure.
Thank you so much. And I want to thank our audience. We have some wonderful questions coming in. Our next question is, my lab follows local guidelines that haven't adopted all the EASL recommendations yet. If we want to follow EASL practices, what can be done?
It really depends. Well, it really depends on the level of freedom you have locally, and the EASL guidelines have been established to be applicable everywhere in the world, and they're based only on the science, the expertise of the people who wrote them, and there is absolutely no constraints related to a local approval of any test or any treatment or any kind of reimbursement policy. So this makes them universal and usable everywhere. But the limit is that if one practice, which is recommended by EASL, is not available in your country, there is nothing you can do, and you cannot use an assay which is not approved or use a treatment which is not approved. So I think you should do your best to apply the EASL guidelines in your practice with the limitation of what is available, allowed, and reimbursed in your own country.
Thank you, Dr. Pawlowtsky. We have some wonderful questions coming in. Audience members from around the world. Here's our next question. If costs were similar and false positive negs are very low, should HCV RNA be used for both screening and diagnosis of HCV? This would reduce barriers of diagnosis and avoid the confusion of positive screen EIA with negative RNA. I think there's a two-part question there. I can repeat part of it if you need me to.
I didn't hear the question. I lost you. I didn't see you. So I see that you're probably listening to me, but I have nothing to answer because I didn't get the question. I'm sorry for that.
Let me repeat that question for you. An audience member would like to know, if costs were similar and false positive negatives are very low, should HCV RNA be used for both screening and diagnosis of HCV? This would reduce barriers to diagnosis and avoid the confusion of positive screen EIA with negative RNA.
Yes, this is a great question, and the answer is definitely yes. If the cost was the same, if it was as easy to do HCV RNA testing as to do anti-HCV antibody testing, definitely HCV RNA screening would become standard of care, and we would have only one step, which is detection of active infection versus nothing. So the answer is yes, but unfortunately we do not yet have the tools for that. If one day we have a test that is able to, on the first testing, determine whether a patient is infected with active replication, it will replace anti-HCV antibody screening. Definitely, yes. Very good question.
Thank you. And here's another wonderful question from our audience. What are some of the common practices for driving public awareness of the need for HCV testing? Can you share any examples that worked well for you?
Well, I can bring the French experience, which has been that the government has decided in 2001 to heavily screen for HCV and put together a national action plan. I think we're the first country in the world doing that. And they decided to inform people, inform the population, so there were spots on TV, on the medias, and radios, and the metro in Paris, and everywhere, about HCV and telling people if you're at risk, and they were listing the kind of risk that could be associated with HCV, go to see your general practitioner. And the second target was the GPs themselves, who were informed about the risk factors of HCV infection and were encouraged to screen for HCV antibodies. And it worked pretty well because in 3 years, 2001 to 2004, we were able to identify 60 to 65% of the patients who were thought to be infected in the country. 100,000 patients were missing, and 10 years later, the number of patients still missing is 75,000. And it's possible that these patients, in fact, do not exist. So it's possible that we've been so good that in 3 years we have been able to identify the vast majority of our HCV-infected patients. I see two risks, two limitations, and things that to be taken into consideration with a lot of care, and it also can depend on the culture of the country and the habits in different areas of the world. The first one is panic. If you start a big campaign for screening, you should not panic people that HCV is everywhere, can be transmitted, etc. And the second risk is stigmatization, and I think this has to be taken care of very carefully. But with these two caution messages, I would say that it's possible to launch campaigns, and I know that other countries have slightly different or similar experiences and have been very efficient in screening the majority of their patients.
Thank you, Dr. Pawlowski. And here's a related question from you from our audience members. Can you comment on why the HBV screening is important prior to HCV treatment? And two-part question, and what other testing may need to be considered when managing patients with hepatitis C?
Another very good question. The reason why it's important to screen for HBV as well is that in the case of HCV co-infection, generally HCV inhibits hepatitis B virus. And if you treat HCV and cure HCV, there is a risk of reactivation of HBV infection, and this reactivation may have deleterious consequences on the liver, such as ALT flares and sometimes acute or subfulminant hepatitis. However, these cases are extremely rare, and most people who are used to see co-infected patients know very well how to monitor them and to prevent it. So the two important markers are HBs antigen, which is a marker of chronic HBV carriage, and patients who are HBsAg carriers should be considered as having HBV co-infection together with HCV, and in these patients, especially if there is detectable HBV replication, it's important to use preemptive therapy, start a nucleotide analog treatment or nucleoside analog treatment for HBV before starting HCV treatment. The other marker which has been highly debated is the isolated presence of anti-HBC antibodies, which in the vast majority of cases can be a marker of past solved infection or can be a false positive. And there have been some reports of very rare cases of HBV reactivation in patients with anti-HBC antibodies present alone without HBs antigen and without HBV DNA. And I think there is no consensus yet, but in most cases the recommendation is just to monitor these patients, follow them closely, but not start any preemptive therapy with anti-HBV treatment.
Thank you so much, Dr. Pawlowski. Our next question is, in case of HCV antibody positive, would HCV RNA not be detected? Should it be treated or not be treated?
A patient who is HCV RNA negative is not infected and should not be treated. It should be explained to this patient very clearly that possibly the patient has been infected in the past, but has been able to cure the infection alone and does not need treatment. And I think these patients must absolutely be reassured, and this is really a very important point. Being anti-HCV antibody positive but HCV RNA negative is being HCV non-infected and not treated.
Thank you, Dr. Pawlowski. Here's a great question, an interesting one. In Latin America, the use of Western blot, how confirmatory test is the first election, now is very expensive. What is your opinion about the use of this test?
Well, I'm going to disappoint you, but I think something like 20 years ago, I wrote several papers showing that the Western blot confirmatory tests were useless to confirm HCV infection. They can only create discrepancies with the antibody test, but it's another type of antibody test. And therefore, the only way to confirm active infection is HCV RNA testing. I understand this test is expensive, The core antigen test is, as we discussed, a potential alternative to HCV RNA testing, but there is no other way to confirm active infection and decide about the indication of therapy but doing HCV RNA or core antigen testing. And really the Western blot, what we call the REBA assay, should no longer be used. We stopped using it 20 years ago in my lab and in all over Europe.
Dr. PAWLOTSKY, this next question is a very interesting one I think everyone would like to know. Is complete eradication of hepatitis C possible with new technologies and therapies?
Well, it's a very good question. The question is broader than that, I guess. The question is, can we eradicate an infection that involved 70 million people without a vaccine? And we will probably never have a vaccine. We only have what we have: screening and diagnostic tests on the one hand, and very efficient treatments on the other hand, with cure rates over 99%. I think with this, we can control infection, meaning that in every country that has a well-organized national action plan, a good screening strategy, an excellent linkage to care, an acceptable cascade of care, and good treatment access, in each country like this, we can make this frequent disease a very rare disease. It doesn't mean that it will be eradicated, that there will be no more HCV infected people in the country, but there will be very few, and sometimes you will see one or another coming from a different area, transmission, high-risk groups, but something very rare, and that will be controlled. If after many years, and I think 2030 is probably a little bit optimistic, not optimistic from Western Europe, North America, some Asian countries, we will achieve it. But in other countries, it will take much more time. But I think at some point, with the very good drugs we have, and if there is a political willingness to tackle the issue and we really do it, it will be possible to make this frequent disease a rare disease. The term elimination, eradication is, I think, less realistic and more political, but sometimes it's good to speak about unreachable achievements to make sure that the politicians support us in the fight, and this is probably why it's being used. But I'm very optimistic that with the good drugs we have, we'll be able to handle this. And in my country, France, we expect that within the next 5 to 7 years, we will have treated all the patients we have identified, and it will be a fast issue.
Thank you, Dr. PAWLOTSKY, and thank you for our wonderful audience today. We have time for one last question, and this one comes from Johns Hopkins School of Medicine. If HCV antigen detection is acceptable to EASL at LLOQ 1000 IU milliliters, why must the HCV RNA NAT have LLOQ of 15 milliliters? This seems inconsistent.
It's a very good question, and I think I know who asked that question. So I will answer again, because I already answered that question in another setting. I think there is a discrepancy in these old guidelines, and the reason why there is a recommendation for high sensitivity for HCV RNA testing is because in the past guidelines, especially the ones we were using for peginterferon and ribavirin, or peginterferon, ribavirin, telaprevir, boceprevir, we needed to be very sensitive, down to 15-20 IU per ml, to detect the response on treatment and treatment duration to that response. And I agree with the person who asked the question that there is a discrepancy, and that currently what we need is to be able to detect replication before therapy, and for this we don't need to be that sensitive. And if we accept that the core antigen test can do it with an equivalent to 503,000 IU per ml of HCV RNA, the same lower limit of detection could be acceptable for the HCV RNA assay. And the other utility of testing is after the end of treatment, SVR12, And again, the HCV RNA level in a patient who relapses is generally high at this time. So I completely agree that the 15 IU per ml is currently irrelevant for the use we have of HCV nucleic acid testing. And I anticipate that there will be some changes in the next version of the EASL guideline that should be published at the end of this year.
Thank you so much, Dr. Pawlowski, and thank you to our audience members. I'd also like to thank LabRoots and our sponsor Abbott today for making today's educational webcast possible. I want to remind our audience members that today's webcast will be available for on-demand viewing until April 2018. You'll receive an email from LabRoots alerting you when the webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thanks again, everyone. See you next time. Bye-bye.